All right, folks. Well, very delighted to have Dr. Jennifer Mack with me on today's podcast on Healthcare Unfiltered. Well, two reasons why I'm very excited. Number one, it's her first appearance. So anytime I have a new guest on the podcast, it's always an honor and privilege. Now, my fear is she never comes back on the podcast. Then hopefully that's not the case. And the second part is really we are going to tackle a topic that's not only difficult, but I really think it's so critical for listeners and viewers. So, Jennifer, welcome to the Healthcare Unfiltered. Really appreciate your time. For context, we're taping this sometime in May on a Friday evening. So I appreciate you jumping on the podcast. Let's just start by giving folks just a little bit of background about you. You know who you are, what you do, and just tell us a little bit about who Dr. Jennifer Mack is.
Yeah, great. Thank you. So I'm a pediatric oncologist. I work at Dana-Farber and Boston Children's in Boston. And those are Harvard Medical School institutions. So I'm also an associate professor at Harvard Medical School. And I do research in issues related to health communication, both in children and adults. A lot of my work currently is focused on adolescents and young adults. And then I also have a role in leading our faculty development office at our institution. And I direct a group called the Center for Outcomes and Policy Research, which includes a lot of, outcomes research, kind of like what I do.
That's wonderful. So are you a Patriots fan?
I'm not really a football person, to be honest.
I ask because I am a Patriots fan. I lived in Boston a long time ago, before residency, before I'm moving to Chicago. So, how, like when you say you do research on communication, I mean, the oncologist in me always thinks of the research more pertaining to, trials, new drug development. What got you interested in this kind of research? It's not the typical path in terms of research.
Yeah, I mean, that was especially true when I was in my training. I think there are more people who do this now, but when I was in my fellowship training, one of the things that I saw clinically was that communicating was one of the really challenging things that we do. And that it was one of our most important tools, one of the most important things that we do for patients and families. But when I went to the literature to try to get guidance on it, there were a lot of papers where people said, here's what I do. But there weren't a lot of papers that actually showed evidence for the right thing to do. And, in everything else, we practice evidence-based medicine, right? We try to find the right thing to do based on the best data available and, rigorous studies. And so I thought, we should be able to study this. We should be able to garner an evidence base that can guide what we do and help us, because this is such an important thing. And I was lucky to find mentors who were interested in this too, and who helped me figure out the tools. And so it's been a really, rewarding part of my career. I think it's endlessly interesting. There's a million questions to ask in this field. And, again, I think it feels so clinically relevant, so relevant to my practice that I always enjoy it.
Well, it is. I mean, let's face it, it's extremely important. I mean, how many times patients would leave a doctor because they just are unhappy, not with the recommendations of therapy, but how they talk to. I mean, this is extremely important. I mean, I'll argue it's part of quote unquote healthcare delivery, right? I mean, you're delivering something.
Yeah.
And there's a lot of questions. It won't be millions, but I have like few things that I would like us, me and you, to discuss. But I also want to confess that what triggered me to contact you with a very, very nice editorial that you published in the Journal of Oncology Practice. I thought it's very nice, and you started by commenting on a paper that was published 2 decades ago.
Mm-hmm.
So I want to start there. What happened 20 years ago that you wrote a paper. Tell us a little bit about the history of that.
Yeah, I mean, I was a fellow then, right? I was in my training and I worked closely with one of our senior attendings, Holcomb Greer, who's still a good friend. He's mostly retired now, but you'll still catch him at meetings. You know, he was very interested in this idea of the day one talk, you know, what we call the day one talk, which is the first conversation about diagnosis and treatment. You know, when we sit down with a family and we say, okay, you know, we know what's going on and here's what we're going to do about it. And and so we decided to write this paper talk about strategies for having this conversation in a way that is informative and compassionate, and you know, all the things that you hope that kind of conversation might be, as a way to give guidance to young people. And so it was, and that was published in the Journal of Clinical Oncology, I think in 2004. And Holcomb and I have taught about this. We've taught our fellows about this. We've taught it. We've actually taught, you know, at our institution, you know, we've taught this to surgeons and anesthesiologists and people from other fields.
If you got surgeons to communicate well, that's it. You're done. You arrived.
We actually work with the best surgeons, and I have to say I learn from them all the time. There's many of them are just incredible communicators. So I'm very, very lucky. But yeah, they invited us to come, you know, talk about that as well, because they struggle with this, you know, and other institutions have used the paper, still use the paper to teach their fellows, which is really fun. So that's kind of how it started. That was my first paper, was the day one talk. And
so let me start there with the day one talk a little bit. I want to, there are times where you know that things are not looking well, right? You could be seeing a patient where it's literally, it's hospice.
Yeah.
And you could see a patient where things obviously are bad, but there are treatments, but the prognosis is not great. Do you feel that all of this must be communicated in the first visit? Is there a process by which the communication should be a little bit tailored? Like, in essence, you really don't want your patient to just completely feel it's doom and gloom day one, and you can filter some of this as you progress in the relationship.
Yeah, it's a great question. And, there's actually a nice pair of articles that a terrific oncologist, Tony Bach, wrote in JCO some years ago about conveying prognosis. And I really like the way he thinks about it, because he thinks about two different scenarios. There are the situations where you feel like, as an oncologist, you must convey this information to allow them to make good decisions. And then there are situations where there's flexibility. And, I think we all have to decide for ourselves what are the musts, but, for me, for example, if I know that a cancer is incurable, I feel like I have to convey that, early on, so that the patient or family or both can make a good decision about the care, an informed decision, about what they would want in those circumstances. I think in other circumstances where you may be in a more gray zone, you can work a little bit with the patient and family to figure out what do they want to know, and when and how. So that's kind of what I use.
Yeah, but how much was this, Jennifer, influenced by your mentor? Because that makes me think about the education process at our institutions. And it is possible, you had a great mentor, you wrote a paper with him 20 years ago, and he taught you this. And I don't know how much current fellows or residents really get a curriculum or a structured teaching into the way you deliver bad news or communicate.
Yeah. Yeah, I think that's very true. And actually, that was one of the things, the editorial that you mentioned in JOP was in response to a study that was done by another group. And I don't think I can tell you off the top of my head what all their statistics were, but one of the things they looked at is how people learn how to do this. And there still in their study was a lot of this kind of see one, do one, type of situation where you watch someone do it and then you do it yourself. And a lot of just kind of learning by doing as opposed to having structured curriculum. And so I do think that's very true that this is not, I think it's become much more common that this is a
Mhm.
part of standard curriculum, but it's definitely not universal. And also I think the quality of different, teaching programs varies and the effectiveness of those programs varies. So, I think there's a lot of room to grow.
Yeah. There are there's the challenge of what you do, in oncology, obviously, is that we don't always deliver good news. I mean, thankfully, things have gotten better. We have a lot of new opportunities to deliver good news. But is there a way that you have been able to communicate bad news or less favorable news while really making sure that the family or the patients are not losing hope?
Yeah, but, people talk about this a lot. How do you do this? And they worry about giving bad news because they think that it will take away hope. Um, I don't know that there's an exact answer to this, but we did a study, I think in 2007, if I'm remembering right, where we looked at the relationship between prognostic disclosure and hope in parents of children with cancer. And in that study, we actually found that the more detail, the more disclosure that a parent received about a child's prognosis, the more hopeful that they felt. And that was the case even in the children with the poorest prognoses. And since then, we've replicated that. We even found that to be the case for adolescents and young adults who we often are very protective of, and so,
Hmm.
even for them, having frank, honest information actually supported hope. And, I can't tell you exactly why that's the case. I do think, well, I have some different theories, and we tried to do some work to try to figure this out a little bit more. But, one thing is that, sometimes I meet parents who don't want me to provide information to their children about the diagnosis, for example, and they're worried that it's going to take away hope. And oftentimes, what we find is that in that case, and of course, this is about diagnosis, not prognosis, but that actually the child has already assumed the worst. They've seen that their parents are afraid or tearful or whatever it is, and their minds immediately go to the worst possibility. And so when they actually get honest information, it's a relief, because they have that clarity. You've taken away some uncertainty around it, and they can start to deal with reality, And I do think that even for the case of a difficult prognosis, that uncertainty can be very burdensome, very difficult to deal with. And once families know that we're being honest and open about this, they can start to grapple with it and deal with it. I know that's not going to be universal, and it may not be, in that very moment that they feel
Yeah,
relieved. Of course they feel devastated, and we see that.
of course.
But I do think that, this is part of what we do as physicians, as clinicians, is that we, we help people to deal with what is, and we don't hide it from them.
Yeah, you've got two things when it comes to communication, and you have family members. You have the scenario of children and adults, right? So there are scenarios where the children or the family members of an adult diagnosed with cancer take you on the side. Hey, doc, can we just not say the word C? Can we, whatever it is, or can we sugarcoat whatever it is? And you've got the other scenario with children. Have you been able to coach healthcare professionals in both scenarios? And are there differences in how you handle these two scenarios I described?
Yeah, I mean, I think actually it's not, I'm not sure if it's so different between children and adults. Very young children, some of the cognitive piece, like the understanding of it, or even developmentally, how they understand these things may be different. But, I think oftentimes the people who we're trying to protect already know that something's very wrong.
Very good
Um,
point.
and, so what they don't know is whether they can trust us to be honest with them. And so at the very least, we, can be a trusted person through that and help them to deal with that. I think especially for teenagers, they're really wondering whether they can trust the adults in their life, right? That's a normal thing for an adolescent to be trying to figure that out. And especially for a new medical team who they don't know, if we're talking with their parents in one room and then coming out and not really telling them much, they're not
But but
necessarily
but
going to trust us.
but the uniqueness with the children, and again, you're the pediatric oncologist, so I'm just hypothesizing, is they're not adults, obviously, so the parents still have the power of whatever attorney, whatever it is.
Right.
So if it's a 12-year-old,
Yeah.
like, do you have to ask the parents permission?
Yeah.
Does the child need to be in the room? And if the parent says no, I mean, like, what I mean? Like, there's a little bit
Yeah.
of
How
a
do you
difference here.
navigate it?
I'd like you to
Yeah.
elaborate a little bit more on this, because as a parent, I could tell you, well, you know what? I respect you, I appreciate you, but he's my child. He's not 18. I want him outside. Do I have the power to say that?
I think that you do. And I think that so for very young kids, we usually recommend a separate conversation with the child that is developmentally appropriate, because they don't need to know, they don't need to sit there for the 2 hours of side effects of all the medications we're going to give, right? They need to know, are they going to stay in the hospital? Are they going to, these kinds of basic things. For kind of the more school age type of kids, we usually work with the parent to see what they think is best. And so those are like 7-year-olds, 10-year-olds. I'll be talking with the parent about what would be most helpful to them. Do they need a conversation with all of us, or do they need a conversation of their own? And we can talk in a second about what the content of that conversation is, right? Because that's an issue. But then for the teenagers, I usually do recommend to the parents that we have them in the room if we can. And again, the reason is that they this is their body, this is their life, this is they have to be taking the medications, going through the therapy, and so for them to have some knowledge and ownership of that information, to be involved, is often very important. And sometimes parents will say no. But oftentimes we're able to kind of talk them through it. And I think one thing that we can do is talk about exactly what we're going to say, because sometimes parents think we're going to say something really, frightening, or something that the child can't bear to hear. And in fact, it's, usually we're telling them things that are helpful to them about what's happening and what we're planning to do. And so oftentimes kind of going through that with them to explain, what it is that we're going to talk about can be very helpful.
Do
Um,
you ever get involved in conversations with the school for children? Do like, in addition, I presume you have to write notes and things like that sometimes, but do parents ask you, what do we tell the school? How transparent should we be? Like, is that part of what you do or no?
Yeah, in fact, we have a team of psychologists and social workers. So for at least for our institution and many pediatric institutions, we have every newly diagnosed child will have a team, will have a psychologist or social worker assigned to their care. And oftentimes that person also helps with communication with the school because there's information that we can provide. We can also help set expectations around whether the child will be in school or will be absent, and what kinds of services they might need. Sorry, I told you my light was
No,
going
no,
to
no. That's
start
like
shining through.
you're coming from the skies.
Um, and so so we often will put them in place to try to help with that communication, and so and help the other kids in school to understand what's going on so that they can be good friends and supporters to the child who's ill.
One of the things that you alluded a little bit to in the editorial, but you were spot on because it's something that I believe relevant to all of us when it comes to communication. And you talk about this is really communicating the numbers. I struggle with this. I'm not really sure how much numbers do I need to deliver or tell people. Like, in other words, if you, let's say, just theoretically, telling a patient and a family your response rate is 25%.
Mm-hmm.
Well, if they responded, it's 100%. If they don't, it's a 0%. So it's not really clear to me how much you do this. So I guess I wanted to reflect on two things that come to mind. One is when you are asked about how long do I have to live? It's probably a very difficult question to answer. And let's just, realistically, it's very common that we are wrong as physicians. We just can't really always be accurate. And number two is when it comes to prescribing certain therapies and things like that, and you want to go through the chances. How much do you really think getting these numbers and explaining them really is absorbed or necessary?
Yeah, I think that it's a great question. So one of the things that we've looked at is how often parents and adolescents and young adults also say that they do want numeric prognostic information. And for both parents and young people, it's about 85% say they do want numbers. And so, that's what I think is helpful about that is number one, most people seem to want numbers, at least at some point. And so it's good to remember that. But I think the other thing that's important is not everybody does, right? And so you can't really make an assumption one way or the other. And so what I usually do is just ask, would it be helpful to talk about, for example, the chances of cure? And if it would be helpful, are you a numbers person? Would you like to hear numbers, or would it be better to hear just kind of in general, in words, what I think is likely?
What have you seen, like when you do you think most people are numbers people, or what do you think?
So in my experience, most people will ask for a number, but not everyone. And there are a lot of people, I find that there, maybe not a lot, but I've definitely experienced a number of people who don't want it at the beginning. But then if I revisit it in a couple of months, they do want it. They're kind of ready for it at that point. And so I think that's the other thing that's important to remember is that, people change. And, I think sometimes we feel like, okay, I addressed this once, phew, they don't want it, I'm going to move on. And that can leave some people with their needs unmet too. And I think another assumption that we sometimes make is that if people really want this, they'll ask for it, right? Like, I don't have to offer it, because if they want it, they'll let me know. But
They may have to Google it and ask Chat GPT right now.
and that, exactly. And so they may look someplace else for it. They may not get accurate information because it doesn't have all the nuances that we look at as we formulate that number. And also some people don't feel comfortable asking. And their studies have shown that men, for example, are less likely to ask for this kind of information. Non-white patients, people of minority race or ethnicity. And so you may be leaving some populations underserved besides, just the individual patients.
Yeah. How about the survival? I think, let's face it, if you believe clinical trial data, you always get median, right?
Mm-hmm.
And then clinical trial data don't reflect patients you see outside of trials all the time.
That's right.
But it is a very tough question to answer. How do you handle that?
Yeah, I think it's very hard. I think that the kind of information we get from trials, like a median survival, is very hard for people to wrap their minds around and understand what it really means for them. And so, oftentimes I'll talk about, like if I'm going to talk about a median survival, I'll try to give them some context, that this means that half of people have shorter survival and half of people have longer survival. And so we're just talking about, this is what's smack in the middle of, of what people can expect to do. And oftentimes at the beginning, it's hard for me to predict where they're going to fall on that range of possible survivals. But I let them know often that with time, sometimes it becomes clearer, and that we can revisit that, so that if I think that things are getting shorter than that, or if I think that things may be longer than that, I'll do my best to, be honest with them when that happens. And then I do try to revisit that, because sometimes you get to a place where you realize that they're progressing more quickly, or they're, just not tolerating things as well. And but we know that from experience, but patients, that may not mean anything to them, and they may be still thinking, okay, 2 years is my time frame, when in my head I'm thinking, oh, this isn't going well.
A lot of time in communicating, Jennifer, this has happened to me, and since you are a pediatric oncologist, I'm certain it happened to you. You say something, but the patient and the family heard something else.
Yeah.
When the prognosis is bad, and somehow they heard the prognosis is better or something. There was something that did not translate.
Yeah.
And you get into this down the road, you get into this awkward situation where you thought they understood what's going on, and you realize they didn't. Mm-hmm. I'll venture to say this will create a difficult visit, a difficult conversation. How do we handle this as healthcare professionals in scenarios where what we are communicating is really not being heard the way we assumed it was heard?
Yeah, I think that's very common. Actually, a situation like that is one of the reasons back in my training I got interested in studying prognosis communication, because I had one of those experiences where I thought I said something clear, and then came to find out later that the family understood something very different. And I think one of the things we can do that can be helpful is to try to just check understanding. And so, after we've had one of these conversations, whether it's that day or what maybe it's at a future visit, we can say, last time we met, we talked a little bit about what we can expect, what we can expect to achieve from the treatment, or what we're hoping for in terms of your survival. And one of the things I've learned is I don't always communicate this perfectly, so it would help me to hear from you what you took away from that.
Yeah. Like
And
kind of repeat what you just heard, but you have to do that before you get to that awkward position. Like you have to do that in the beginning, the first couple of visits.
That's right. That's right. If you do it sort of down the line, and then it doesn't give you the same chance to correct things. I also think it can be kind of a delicate conversation. You have to be a little thoughtful about how you ask it. That's why I usually say I've learned I don't always do a great job of communicating this, because I think every now and then, depending on how it's asked, I've seen families feel like someone was questioning their intelligence, or, and of course you don't want to come off that way. It's more that this is just very complicated information. They're emotionally overwhelmed sometimes, which impairs processing, and, there's just a lot to it. So
I'll have to tell you, one of the things that kind of frustrated me is sometimes communicating adverse events and side effects. I mean, it is impossible to be inclusive, right? I mean, you have like the top 5, 6 side effects that's going to happen with a particular regimen, but we've all had seen unusual side effects, things that didn't happen. And you get this, well, I didn't know that. You never told me that. I wouldn't have gotten that chemotherapy had I known this. Maybe I'm sure there's no really cookie cutter book to how you do this, but have you also encountered scenarios where there has been this issue pertaining to side effects?
Yeah. I mean, I think that it is true that things happen that we don't always prepare people for, and we might know it's possible, but we know this whole range of possibilities. And so, when that's the case, I just try to be as honest about that as possible, and own it and apologize, that I didn't prepare them for it. I think that I know why we sometimes don't communicate every detail, of these rare things. But I think when that rare thing happens to a patient, they wonder why that didn't happen. And so I think trying to defend it or explain it is not always that helpful. I think often what they want to hear is that that you're sorry.
Yeah. The other thing is, I think we talked about the kids piece and all of that, but for adults, if the family doesn't want the adult to know, I mean, we should still let the adult know. I don't know how do you coach people around this, but some of this is cultural, right? I mean, as you know, the US is a melting pot, and we have different cultures, different ethnicities, and it depends on the culture when the family is from. It's not that uncommon, frankly, to get you aside of the room. And there are times, believe it or not, where it happened to me. I walked in and the patient was in the waiting area. I only saw the family. This has happened, and not commonly, but it has happened twice that I can remember. So how, I don't know, like, coach me, what do you do in situations like this? Do I stick to my guns and say, I must bring, I don't know, like, I don't know what the right approach.
I think it can be helpful to, first of all, I think you'd want to get the patient's permission to talk with the family. It's probably
Right.
implicit because they're sitting out there and the family's
Right.
there. But I might start by saying, look, I just need to check with your mom or whoever and make sure it's okay for me to have this conversation with you. And assuming it is, then, I think the first thing is just to kind of hear what their concerns are. What are they worried about? What are they imagining could happen? And we know what they're probably worried about, which is that it's too stressful for the parent or whatever, but just to kind of hear them out and understand it. And because, at that point, you don't know them, right? And
Right.
they don't know you. And so it's a chance for you to hear, maybe there is some valid concern that you don't know. I mean, the concerns are valid, but you know what I'm saying? Maybe
Right.
there is something that might make you say, oh, this is a terrible idea for me to disclose this information. And also it just gives you a chance to kind of talk it through with them.
Yeah.
And they, if they know you a little bit better, they may actually, strangely enough, I think much of the time things sort of work themselves out.
You bring up a good point. I mean, when you think about it, this family and patients are meeting a stranger, complete stranger,
Yeah.
at the most vulnerable time of their lives.
Yeah.
And they're supposed to trust that person individually right away. So I could
Yeah.
appreciate the difficulty in things. How about code status and DNR status? Is there a particular time where it is best to communicate and discuss this? Do you need to do this in the first talk, for example, or this is later on because just depends on how things are going?
Yeah, I mean, for my own practice, it's usually later on because, even children with poor prognoses from the beginning usually have some time, before that's going to be urgent. Um, but I think that it's a conversation. Sorry about the sun.
No worries.
It's a conversation that tends to come up when I'm generally talking about goals for care. Maybe I'll scoot over here.
Yeah, you've got the
Um,
right office. They gave you the corner office, it looks like, with a lot of sunlight. So you're lucky.
it's true. It's true. So oftentimes, if I'm starting to think about what's really important to them in their care and what they want their care to look like, then that's kind of the time to think about, what they want in terms of interventions and
Yeah.
that kind of thing. And so to me, that kind of goes together. And so when it's the right time to be kind of thinking about their goals and especially if they're talking about, wanting care that's more focused on quality of life and comfort, then that can be the right time to say, okay, well, maybe we shouldn't be doing all the things that we're able to do. Maybe we should do everything we can to make you comfortable, but not do these other things to prolong life without focusing on comfort.
What other things, I mean, in communication that these are things just I can think about, and I mean, I could, do there are times I presume where folks just, go and get a second opinion, which is appropriate all the time.
Yeah.
But there are times they do this because of the lack of communication. I guess, what other topics within communication you think viewers and listeners really should be aware of that you as a researcher in the field feel are important? And B, do you feel that now the curriculum for current fellows, residents, and graduates is better, where they get a little bit more training, whether it is role playing and things like that? I mean, I don't know how you teach that because it requires really creativity to teach it.
Yeah. Yeah. I mean, I think with respect to the first question, what other things are important to know? One of the things that I think is important is that a lot of what we think about when we think about communication is what we say. right? But there's a lot more to it than that, And so I think that it's equally important to listen and to understand how to listen and how to, bring out people's stories and experiences and their wishes and, all of those things. That's as important as the things that we say. So I think we forget that a little bit. And certainly when we think about communication, a lot of what we think about is what am I going to say?
Yeah, yeah,
And
yeah.
and I think communication has these other roles too, like helping patients to manage their emotions or supporting their emotions and these other pieces that are not really just about information and decision making. So I think those are things that we just so easily forget because so much of what we do is really just sharing information.
Are there any questions, Jennifer, I should have asked you about the topic other questions? Do you feel that we've covered everything? I mean, it's a tough topic. It's a broad topic, but there may be certain things that I should have asked you or you want to mention that you can probably go ahead and tell us.
Well, I mean, you've asked such great questions. I think that, one thing you've brought up education, and one thing that we didn't really talk about is how hard it is to really move the needle on improving communication, even with very thoughtful interventions. So there have been a number of different interventions intended to improve communication about prognosis, going back to the support study, from I don't know 25 years ago or something that was conducted and up through now, and it's been very, very hard to improve communication about prognosis, to improve understanding by patients of prognosis, and to improve the kinds of decisions that patients make. So there's a lot still to be learned about how to teach it and how to do it in a way that really changes care. And I hope that there will be a lot of continued work to figure this out because it's not so easy.
Yeah. Well, this was great. It's a topic that is so important because cancer is a very complex diagnosis. There's a lot of nuances to it, to your earlier point. And I think there's a lot of information out there. And, by the time the patient saw you, they've done a lot of homework, which is good. Nothing is wrong with that. But sometimes that could actually make it a little bit more challenging because some of the information they got may not be accurate and other things. But I really appreciate you shedding some light on this. I think we should do really more episodes that are pertaining to communicating with patients. And there's so many examples out there. Maybe we'll end up on a note pertaining to what has been, because you're very interested in outcomes research on patient-reported outcomes. I view this a form of communication. Because oftentimes a physician walks in the room and they have a review of system thing and they ask questions direct and sometimes thoughtful, obviously, pertaining to the actual disease and the actual drug that's being used. But it may not be really what the patient is worried about. You could ask about neuropathy, vomiting, nausea, diarrhea, and the patient is really worried about the headache they're having. So put on your outcomes research hat, and what are your thoughts about patient-reported outcomes, how often this is being used right now, and where we're going from there?
Yeah, I think that's a great question. So, I think that there's been increasing research on patient reports of their symptom experiences, for example, in oncology. And in the adult setting, patient reporting of their symptoms has been associated with improved quality of life and maybe even survival, among patients who directly report their symptoms through through a reporting system as opposed to having providers just do that assessment. And we found, we've recently developed measures for children as well, with that work led by Bryce Reeve and Pam Hines. And a lot of the work in oncology, in adult oncology, was led by Ethan Bash. And but I think there are still some challenges around this. And, one of them is sort of the nuts and bolts of how to do it, how to collect this information routinely, and then how to transmit that information to clinical teams in a way that allows them to change care and, improve care for those patients. And so it's really that kind of implementation piece that I think is still to be understood. And, there's a lot of work going on now to try to understand how best to do it. And so it's really an interesting growing field. And, I think has real potential to make care better for patients, but still some
And
work.
it is a form of communication on the opposite end, right? I mean, the patient is telling you what matters to them, so they're communicating that with you.
Absolutely. Yeah. And as you say, there are real differences between what patients will report on a survey of their symptoms and what a doctor will report
Big time.
about that. Yeah. And actually for children, we've also found that children have differences from their parents, and their parents are not very accurate reporters of children's symptoms, which you would think that parents would be particularly good at it, but they just don't fully know that experience. So it's important to let the patient be their own voice.
Well, I really appreciate you visiting with me on the podcast. It means a lot to me, listeners and viewers. It's an important topic, and I hope that we can have you again, maybe next year or something, as we just learn a little bit more how things are changing. Because what I would like to cover, and I have not, but I don't think it's timely yet, is honestly, I think with AI and machine learning and the World Wide Web is going to change significantly with AI. So I'll be very interested in your thoughts next year. I kind of feel there's an editorial coming next year about discussing that topic. So I'm going to stay on the lookout for that one.
Sounds great. Thank you so much.